Thank you. I'd also like to thank Drs. Leonard, Coleman, Furman for this kind invitation. So for the next 20 minutes or so, I'm going to talk about how we use cell of origin and double protein. And just to kind of put this out there, I'll say germinal center, non-germinal center. Sometimes non-germinal center on the slides is ABC. And when I say double expression protein, it's the same as double protein lymphoma. So there's a few confusing points there. Now, you might wonder why these two topics were put together, and I think by the end of these 20 minutes, we'll have a better understanding. So we all define diffuse large B-cell lymphoma as this neoplasm of large lymphoid cells with a diffuse growth pattern. But as we've learned, this is really an umbrella term, and there's a number of different clinical pathologic subtypes, gene expression profiling subtypes, and altered protein expression, in addition to what we already knew in terms of morphologic variants that really all fall within this same diagnosis. The clinical impact of this heterogeneity is on outcome. So R-CHOP is an excellent standard of care, but it turns out it does not serve all populations the same. And in fact, the curability sequentially decreases when we start to look at some of these higher risk group subtypes. And what we know now is that it's probably time to move beyond R-CHOP for all patients and to start looking at some of these subtypes in more detail. If we look a little bit more deeply into the numbers, we see that the frequency of these various subtypes is variable, and fortunately double-hit lymphoma, which Dr. Naban will cover, is relatively rare. But what we also see is that overall survival for any one of these high-risk subgroups with R-CHOP is really suboptimal, and there's plenty of work to be done. Cell of origin is perhaps one of the first ways that we started to divide and look at the biologic heterogeneity of diffuse large B-cell lymphoma, and we've known about this now for over 15 years. What we know is that diffuse large B-cell lymphoma can be dichotomized, at least using this model, based on which phase of B-cell development the lymphoma derives from. So if you look at the cartoon on the left, and we look at a normal B-cell traversing its lifespan and exposure to antigen, those cells that turn into a diffuse large B-cell lymphoma at this point have a gene expression profiling pattern similar to normal germinal center B-cells. Whereas if it's a plasmablast or a more activated B-cell, you get a different phenotype, and that leads to the activated B-cell-like or the non-germinal center phenotype of diffuse large B-cell lymphoma. And I think we've all seen these curves a number of times, showing that if you have a gene expression pattern that's more similar to the germinal center, you have a more favorable outcome than those who have the non-germinal center or the ABC subtype. But outside of prognosis, can the differences be exploited so that we can start to develop predictive biomarkers, where we can start to understand how these are different, not just prognostically, but pathogenetically? And the heat map here very pictorially shows that there is a very big difference if you look at gene expression profiling, with the original one being about 20,000 genes between these two subtypes. If we then look to see which pathways are activated, we know that in ABC subtype of diffuse large B-cell lymphoma, we're more likely to have BCL2 amplification, NF-kappa B signaling, trisomy 3, and activation of the INK4 pathway. In contrast, the germinal center type of diffuse large B-cell lymphoma is more likely to have a BCL2 translocation and to have several abnormalities, including P10 deletion and a mere 1792 abnormality that lead to abnormal PI3 kinase signaling, or at least reliance on PI3 kinase signaling. So perhaps we can start to tease out different targets based on this cell of origin model. So over the next few slides, I'm going to describe 3 targets that have been looked at so far and some of the preliminary data that we have. The first one is to look at increased NF-kappa B signaling, which seems to much more closely parallel those patients who have the non-germinal center or ABC subtype. Some of the preliminary data supporting looking at NF-kappa B inhibition in diffuse large B-cell lymphoma comes from the National Cancer Institute, in which they looked at patients with relapsed or refractory diffuse large B-cell lymphoma, treated them with bortezomib, but more importantly, combined bortezomib with dose-adjusted EPOCH-R. This was a negative study right here. I think we all know relapsed refractory diffuse large B-cell lymphoma, very few single agents actually can show an effect. But what was interesting about this portion of the study is that when they looked at the outcomes, they found a reversal of prognosis or outcome here, in that patients who had the ABC subtype actually did better than those who had the germinal center phenotype. Another study supporting NF-kappa B signaling is from Cornell, in which bortezomib was added to R-CHOP. And here, as a single-arm study, it doesn't project very well perhaps, but the germinal center and non-germinal center phenotypes had very similar outcome in terms of progression-free and overall survival. What this suggests from this study is that the addition of bortezomib overcomes the negative prognostic significance of non-germinal center phenotype and really set the stage for a prospective randomized trial. So this is the pyramid study, which Dr. Leonard presented at ASH last year, and he was kind enough to share some of his slides. So this looked at patients with previously untreated diffuse large B-cell lymphoma and selected out those with the non-germinal center phenotype. Now, importantly, the way non-germinal center was defined in the study was not by gene expression profiling, which was the gold standard, but by using an immunohistochemical algorithm, or the Hans method. This has the advantage of being much more widely available. It's very straightforward. It does have about a 20% error rate, but can be done relatively quickly and is quite standard at many institutions. So using this type of algorithm, patients with a non-germinal center diffuse large B-cell lymphoma were randomized to either R-CHOP, standard R-CHOP, or bortezomib plus R-CHOP, or the VR-CHOP arm. The primary endpoint was progression-free survival. The patients who were enrolled were very well balanced in both arms, and I'll just point out that about 40 to 50% of patients were over the age of 65. About 45% of patients had high intermediate or high IPI, which is typical for diffuse large B-cell lymphoma and older patients, and more than half the patients had an elevated LDH. In this setting, unfortunately, the results were negative. There was no improvement in either progression-free survival, shown on this slide, or overall survival, which I did not include. And we start to wonder, why might this be? Well, one of the things that Dr. Leonard had suggested is that at least a part of the reason this was a negative study is a selection bias that even a randomized phase 3 trial cannot overcome. And that is that if you think about all patients with non-germinal center diffuse large B-cell lymphoma and you think about them as a pool of patients, there's heterogeneity even within that subtype. There are those patients who have less favorable disease and those who have more favorable disease even within this one subtype. And of course, if you look retrospectively, as in many of the studies that have looked at cell of origin in the past, you get to include everybody. However, when you do a prospective trial, by necessity, those patients who are the sickest are not going to be able to wait to get their cell of origin determined, even if it's by immunohistochemistry, and are not going to be able to go on to a clinical trial. So this type of bias is likely to impact almost any study that's going to look at diffuse large B-cell lymphoma, and is something that we need to think about as we design our trials going forward. That being said, however, there are two other targets that are being evaluated in diffuse large B-cell lymphoma, specifically in the non-germinal center phenotype. One of them is lenalidomide. So lenalidomide, as we know, has multiple effects, and its effects and efficacy may depend on the cellular context and the disease it's being studied in. What we know is that in non-germinal center diffuse large B-cell lymphoma, there is rationale that it may be preferentially more active because it blocks NF-kappa B signaling, it blocks some of the B-cell receptor activation pathways, and it is downstream of MIT88, which is abnormal in a small percent of patients with diffuse large B-cell lymphoma. In addition, a group from Roswell Park showed that lenalidomide in the relapsed and refractory setting as a monotherapy is more active in non-germinal center diffuse large B-cell lymphoma than germinal center, and set the stage to look at differential effects of lenalidomide added to R-CHOP. The Mayo Clinic group looked at this retrospectively in their R-CHOP patients, where they again showed that germinal center patients have a more favorable outcome than non-germinal center. They then did a prospective trial of R-squared CHOP, or lenalidomide plus R-CHOP, and found, similar to the bortezomib data, that the addition of lenalidomide seems to negate the negative effects of non-germinal center phenotype. And this was true both for progression-free survival, shown in this slide, as well as overall survival, shown in this slide. And this has been the rationale to start two different prospective trials that are ongoing, comparing R-CHOP to R-squared CHOP, specifically in the non-germinal center phenotype of diffuse large B-cell lymphoma. The third agent I'll mention is ibrutinib. And that is because, again, with non-germinal center diffuse large B-cell lymphoma, chronic active B-cell receptor signaling appears to be a very important pathogenic lesion. And we know that a portion of patients will have CART11 mutations, others will have mutations in the ITAM motif, and overall leads to chronic active B-cell receptor signaling. Again, in the relapsed and refractory setting, there is support that ibrutinib, which blocks B-cell receptor signaling through BTK, is preferentially more active in the non-germinal center phenotype. And this has led to the Phoenix trial, which is also ongoing and I believe almost completed, that again uses immunohistochemistry to define this subgroup and randomizes patients to R-CHOP with or without ibrutinib. And hopefully over the next year or so, we'll get some of these results. Now, one of the things I've gone back to is this whole concept of how do you define cell of origin. And gene expression profiling, which was the gold standard, requires frozen material and is not necessarily practical in terms of how biopsies are done and stored in clinical practice. The immunohistochemical algorithms, as we've already said, have their own problems in that there is a relatively high error rate and there may be some inter-user variability. I think going forward, what may make a difference is the use of nanostring. And there is now a commercially available, although I think it's still being used primarily research-wise, an assay called Lymph2CX, which looks at 20 genes, not 20,000 genes. And if you can see just down here, they compared the Lymph2CX against the gold standard of gene expression profiling, and this seems to be a more robust way of determining cell of origin. So if we're going to use cell of origin going forward, I think we're going to need to have something that has a rapid turnaround, that can be used in paraffin-embedded tissue, and is relatively accurate if we believe cell of origin makes a difference. So I said at the beginning I'm going to tie in double expressor lymphomas. So before I do that, let me define what double expressor lymphoma means, because this is something that's relatively new, but I think it's here to stay. So we know that the WHO updated their classification of lymphoid malignancies earlier this year. This was published in Blood. And what they took into account is that you start with morphology. And if patients have a MYC or a BCL2 rearrangement, those patients are all separated out and called high-grade B-cell lymphoma. Everyone else is diffuse large B-cell lymphoma, NOS. Amongst that group, for the first time, the WHO recognized that co-expression of MYC and BCL2 is considered a new prognostic marker, and they gave it a name, double expressor lymphoma. They used cut points of greater than 50% BCL2 and greater than 40% MYC. And if both of those proteins are abnormal, that would be called a double expressor lymphoma. And remember, this is without the underlying rearrangements of MYC and BCL2. Why does it matter? Well, two reasons. One is that it's much more common than double hit lymphoma. If you look at the frequency of MYC rearrangements, it's relatively low, but if you look by MYC by immunohistochemistry, it's at least a third of patients. Same thing with BCL2. Rearrangements are about 20 to 30% of patients, but immunohistochemistry shows that a significant portion of patients will have overexpression. Altogether, about a third of patients with diffuse large B-cell lymphoma will have dual BCL2 and MYC rearrangement. So the first reason this is important is that this is more common than double hit lymphoma. The second reason is that it clearly impacts outcome. So if you look at, this is a very large series of 800 patients or so that has no double hit, so no underlying rearrangements. So just the presence of those two proteins alone leads to a significantly inferior outcome when treated with standard regimens. Looking specifically at R-CHOP, you can find that, again, this study found that double hit lymphoma is relatively uncommon. Double protein lymphoma, here they called it DHS2, accounts for about a third of patients. And if you have just MYC or just BCL2, it didn't seem to matter. It's the co-expression of both of those proteins that leads to an inferior outcome with R-CHOP. So this is what you expect with R-CHOP, certainly not what we would want. How does this tie back in to the cell of origin? Well, if you look at gene expression profiling, depending, again, on the cellular context, whether it's an ABC or a germinal center diffuse large B-cell lymphoma, and then look at the double protein, it looks as if different genes are activated. So the groups are getting a little bit more complicated and a little bit more mixed. So it might lead you to ask, we've talked about cell of origin. I'm going to leave Dr. Naban to talk about double hit, but double protein, what else is important when we try to subdivide diffuse large B-cell lymphoma? And I think the challenge is that these risk groups really overlap. We know that cell of origin, germinal center diffuse large B-cell lymphoma is more likely to harbor a double hit, and non-germinal center is more likely to harbor a double protein. And we haven't even started to look at some of the other mutations. The data supporting that these trends occur, that double hit goes with germinal center and double protein goes with non-germinal center, is summarized in this slide, which is a little busy, but I'm going to just walk you through a little bit of it. So for one thing, in this study of almost 200 patients, 91% of all the double hits occurred in a germinal center diffuse large B-cell lymphoma. In contrast, the majority of patients with the double protein lymphoma occur in the non-germinal center type of diffuse large B-cell lymphoma, and there's a clinical phenotype. Patients with double protein lymphoma are older. They're actually a decade older than those patients who don't have either double hit or double protein. They have a poor performance status, more advanced stage disease, more B symptoms, a higher IPI, more chemoresistance, and again, more ABC subtype. Looking just very quickly at some of the other primary data, the co-expression of these proteins is higher in ABC diffuse large B-cell lymphoma, and this even seems to overcome the impact of the IPI. So if you look up here, those patients who have an IPI less than 2 but no double protein do much better than those patients who have an IPI of 2 but have the double protein. So this is what you get no matter what your IPI score is. And looking at the data a slightly different way, if you take out all of the patients, if you just look at the ABC subtype of diffuse large B-cell lymphoma and you pull out all the double proteins, those patients who don't have it do much better than those patients who do. And this paper very provocatively said that these authors believe that almost all the negative significance of non-germinal center diffuse large B-cell lymphoma is because of the double protein expression. I think this is a little controversial, but at least those were the conclusions of those authors. There may be a way to integrate it, and there's at least one attempt so far to try to look at all three of these prognostic factors, cell of origin, double hit, double protein, and IPI. And this study basically showed that all three variables are important and that cell of origin may be most important in the intermediate IPI and the non-double protein groups, and that ABC diffuse large B-cell lymphoma patients were more likely to have a high IPI. Importantly, dual protein expression brought down both curves no matter what subtype you were looking at. So I think, the answer to the question is, am I using this to treat patients differently? And the answer is no, because I think that right now the data is very murky. There are reasons for negative trials that we can try to rationalize, and we have no clear way to say that these patients definitely need to be treated differently when we meet them as an individual. We know as a group they do, but there's too much variability. There are a number of trials that are ongoing. At the University of Chicago with Dr. Naban, we have a phase 1 trial of lenalidomide plus EPOCH-R specifically for double protein lymphoma, which will be a poster at ASH. There is an intergroup study that Dr. Leonard will be leading that adds venetoclax to dose-adjusted EPOCH-R for double protein lymphomas. And we can start to think about different agents that we want to look at specifically in these subsets. It may be that we have to not necessarily look at how these proteins and genes are abnormal, but perhaps just target the end product, which is MYC overexpression and BCL2 overexpression. I do think that one thing we can do in this room and beyond is to make sure we have tissue. There's no way we're going to be able to move forward in diffuse large B-cell lymphoma without understanding more about the biology and how we can start to parse out these different subsets at an individual level. We need to have a better way to biologically risk stratify patients that has this data available to us in a reasonable time frame, that it's accurate, and try to integrate all the different prognostic factors. And we certainly need cooperation across groups and have trials that are specifically powered for subsets. So today I would say we have many questions and no answers. I still use R-CHOP outside of a clinical trial for ABC and GC diffuse large B-cell lymphoma. I think there may be a difference between double hit and double expression lymphoma, and maybe Dr. Naban will tell us more about that. And I do think the cell of origin matters, but I think it's somewhat attenuated when you start to add in the double proteins. I didn't talk about autologous stem cell transplant, but through SWOG, we did look to see if a consolidative transplant helps. And unfortunately, similar to the pyramid trial, very few patients with these abnormalities are enrolled. And we ended up with only 16 patients out of a group of 400 or so that we looked at. So with that, I'll just say there are definitely more questions than answers, but I'll try to do my best to answer any that there are. Thank you.